try to boil the ocean over there. And I think you said it early on in your talk, that there are hard problems, there are easy problems, and you're going to try and at least tackle the easy problems. But I guess, let me paraphrase some of the point that Mark was making, is that, are we focusing on the wrong thing here? Is the real elephant in the room the affordability? Or what is it? I mean,
I think it's a combination of things. But I mean, I'll speak from personal experience. I just had, my insurance company just decided to stop paying for one of my medications. Well, if I don't take that medication, the other medication I do take can cause cancer. So I went after the insurance company and said, what are you doing? You know, in 6 years you're going to be treating me for cancer and it's going to cost you a lot more. Why would you do this? So I'm having to provide...
What was their answer?
Well, I'm in the process of providing umpteen's number of pieces of documentation. My physician's trying to provide documentation, literature, so that they can see this. Because people who are in insurance companies, unfortunately, are making decisions about something they know nothing about.
Well, that's, yes. You know, and that short-term thinking that you're going to be in their plan on average for 18 months, you know, between 1 year or 2 years.
I've been on their plan for 6 years, so you know, I don't...
You're long-term, you're a lifer as far as they're concerned. Yeah, that's part of it. So we're kind of... it's always a multi-headed problem. And I mean, I want to say I applaud the efforts of everyone here trying to push pharma into the new era and push the boundaries out in all cases. And I know in some cases you don't always know where you're going to land, but hopefully you'll all land in good places. So, okay, I reckon.
So I think there's another paradigm, and that is the emerging of alternative medicine. Yeah. And I think last year, from what I heard, or 2010, that for the first time alternative medicine actually surpassed conventional medicine. And I think that also playing a huge role on why people are not going to take their regular pills, and also the other type of information they're getting on the media, that for example only 4% of cross-drug-based medication is actually help only 4% of the population that they take it. Yeah. So all this kind of messages comes from different direction, and I think that even changes the whole dilemma more. I think for Nancy sort of point, and I think alternative medicine, having that kind of stuff filled into your vitamins, for example, would be much more, gets much more to the consumer market, because we want to know if that vitamin D really works or doesn't work. Whereas with my cross-drug, I wouldn't know about it until...
That's a really good thought, that it's the self-care market, or the self-prescription market, if you will, that's probably much more interested in tracking the effect of... You have a comment on that, or...?
Yeah, actually, I think it kind of fits in with what Gil was saying earlier about feedback, and basically our traditional health system, you know, where you get prescribed a drug, like you said, there are big problems, and I'm not surprised that people don't trust the medications that they're taking and just don't take them, because they don't work for most of the people in many cases. So I think systems of technology that give you that feedback, that can actually tell you, you know, this is working, this isn't working. If you can get consumers to trust what they're taking, they're much more likely to want to participate. And it kind of fits in with the whole holistic medication as well, because our healthcare system also just looks at you and says, you should take this, you need to take this, it doesn't matter why, do it. And increasingly people have access to information and they want to be part of that. You know, they don't want to sit there and be talked down to and told, this is what's best for you, I know, like, don't give me any more information, just listen. They want to start...
know which decade she was born in. Sorry.
There are more and more of us.
I know. And we're counting on you to take care of us, so... We've screwed up the world, right? So I appreciate that. I mean, would you consider apps an alternative form of alternative medication? I mean, in some, you know, if it's ultimately creating better health, you know, so the aptique that Sean mentioned is probably a parallel to...
There's no question that if you're seeking behavior change, apps are, I would say, the low-hanging fruit. I would encourage all of you to talk to your patients about what apps they're using. Not just medical apps, but apps in general. The convergence between the time that people are spending in the digital sphere and their health, it's coming. More and more of these, I mean, even something as Farmville. Like, there's people that spend a lot of time each day using Farmville. What if there were a reminder in Farmville to take your medication? What if you turned that on because you knew that you had a vested interest and you wanted a reminder, whether it was a text message or a message in Farmville? I think you got to really push your patients to help you understand how are they interacting with technology? Because with their cell phones in their pockets all the time, if you want to drive behavior change, that's an opportunity to do so.
There was a question back there. Yeah, please.
Yeah, I have this idea of where I know you're maybe not into like hearing government solutions instead of technology, but the affordability, which I still think is the elephant in the room. I was thinking in terms of like how we pay farms not to grow food sometimes. How about if we pay pharma if they're able to reduce the need for a pill? You know, like, because they make all this money, they're thinking money, a lot of them.
Right. So there's actually I heard this at the JP Morgan conference earlier this year about.
Oh, good. Bankers.
What's that?
Bankers, I said.
Bankers. No, but it was actually I think it was a presentation by Mark McClellan, who used to be the former commissioner at the FDA, one of the examples he gave of new models was, precisely speaking to that, was, I believe it's a reimbursement model for a particular, I think it's hypertension drug, and the name escapes me, and I'm sure you can look it up, where the reimbursement model is, there's a very low baseline reimbursement, and as the health outcomes are tracked and proven, the reimbursement goes up. So this is where they're paid to put their money where their mouth is, basically, and if they say a patient needs X dosage prescription or X level of prescription, if the pharma says that, they have to prove that that's what's appropriate for the patient in terms of outcomes before they get reimbursed. So it's a risk-based reimbursement or an outcomes-based reimbursement model.
Well, I had a question for him, but now I have a question for you. I mean, the pharma company doesn't touch the patient. So how can the pharma company be held accountable
this is exactly where all of the tracking technologies come into play.
So now we have big pharma coming into your brain, your black eye.
Build it and they will come, right? So now pharma companies, but that's...
Well, I just want to add, I really, and with all my heart, I do not think that healthcare professionals should demonize big pharma. Yeah, they paid my bills for 7 years and helped me pay down my student loans, but a lot of your peers are in pharma. There's a lot of good people in pharma, and they have a lot of resources that unfortunately are going to waste because the companies are slowly dying. What we're chasing with Needle is the emerging stakeholders in pharma, which happen to be compliance and regulatory, and medical affairs. I think you're going to find a sea change happen soon in pharma. Most big pharma companies are run by guys like me that carried a bag and rose the ladder, salespeople. Pharma is driven by sales, but the change is happening. The DIA conference, Drug Information Association, medical affairs is rising, and I think that all of you that might have cynicism about pharma, I hope that changes as you see more of your peers rise in pharma, as the customer-facing person in pharma becomes one of your peers, a PhD, a PharmD, an MD, versus a salesperson. I hope that that changes, because ultimately it's the same pot of money. It's money from your institution that's going to pharma. It's money from employers and insurance companies going to pharma. The best possible way we can solve our problems in healthcare is if you guys can recoup some more value from pharma, because pharma is still cash rich and very resource rich. But you know, engagement is always better than antagonism. And so I think, you know, that's just from an ex-pharma guy who does feel a lot of values in pharma.
Where it's open season on anyone we can demonize. So it wasn't reserved for pharma anyway. But there was a question here.
My question is somewhat related, actually. We talked about pharma, we talked about the insurers, we talked about consumers. But what's the role of government in this? Because the government is talking about citizens' health. Citizens, unless the citizens are healthy, it has a direct impact on the economy, the GDP, and all that stuff. So where is the government coming in here?
It depends on whether you're red or blue, I guess.
I'll say from our end,
yeah.
we've been contacted by several public health agencies that are very interested in the stream of questions that we're generating from one hospital in Minnesota. What's on healthcare professionals' minds?
Yeah.
Could this be a form of an early alert system if we're observing questions about adverse events? There's definitely a lot of interest from the government for saying, how can we apply some level of transparency to the questions that healthcare professionals have? And if we notice any types of trends, is there a way for us to be proactive? Is there a way for us to correlate questions with inappropriate marketing by pharma? But the big thing is the early alert possibility. We have questions about adverse events come in all the time. We have a protocol for how we deal with those because pharma has FDA guidelines about how they deal with those. But ultimately, that's a good thing.
But I think the question was not just about the part of the government that provides healthcare, not the public hospitals and the public healthcare systems, but I'm guessing the broader role of policy and legislative policy that the first question was asked. If someone wants to answer that real quickly, Scarlett, maybe if you have a thought, that's great. Otherwise, I'll go to one more question, and then I think we may have time for one last question after that. So you're next.
Great. I just wanted to reflect on the robotic pharmacy for a minute. I really applaud you for doing that, even though it's expensive. Having been a victim of therapeutic mixed adventure as a physician, I had a patient who was on Roxanol, and next morning was breathing 4 to 6 times a minute. Was fairly arousable. And when we look back, what happened was the Roxanol was actually something in a bottle that the nurse then diluted in the nursing station. Well, a lot of conversations going around and a lot of distraction. And what's interesting to me is there's a lot of stuff that happens, I think, at the bedside that could benefit from automation, particularly that kind of maneuver. Question, how do you handle that kind of stuff at UCSF at the bedside? And have you seen any kind of robotic devices or automation that might deal with that, the nurses having to mix drugs or what have you? Because I was shocked, actually, when I saw
California
that
state
happen.
legislation, nurses are not allowed to mix at the bedside unless it's an emergent situation. So our nurses do not mix or compound anything. The only time they can do it, like I said, is an emergency situation, a code where it doesn't come in a form that you can administer directly.
Now, this happened about 7 years ago. But.
Yeah, but pharmacists attend every single one of our codes, so we're a little bit different. We have a huge pharmacy staff. I know there's still compounding that goes on. There's 2 companies that I know of that now have a device that you hook onto the IV tubing line that, and I don't know all the technical terms, it reads some kind of wave system and it can tell you exactly what that drug is and the concentration of the drug.
Right.
They're still working on it to get it foolproof. I mean, there's still some variances to it. But that would be something that would be worthwhile. I will tell you on the pharmacy side of that, it scares the living daylights out of me having the nurses have that available to them. Because right now, if I make a concentration of a drug and it's 4.99% or 4.99 milligrams per ml concentration, and it's supposed to be 5 milligrams, I'm allowed a 5%, we allow a 5% variance. The industry allows 10% variance. That nurse will bring that back to me and ask me to remake it, So there's always a little variance. You have to have a little bit. But I think that taking compounding out of someone's hand who doesn't really understand compounding or know it, can be distracted, it's not in the right environment, is definitely a plus. It should, and it needs to be done in a controlled environment, sterile, whether even it's oral. We do all of our sterile compounding in a controlled clean room. Not to the extent of an IV clean room, but it's still a controlled environment.
Can I ask quickly,
Sure.
Outcome, because we're interested in outcome. I know you spent $50 million. Are you tracking to see if you actually reduced adverse drug events that were related to the kinds of things that were happening in the pharmacy that you've automated?
Yes, we look at our compounding, whether or not the right dose is going out, how frequently there's still a compounding error. I will tell you, the robot unfortunately doesn't make mistakes unless you garbage in, garbage out. You put the wrong data in, the wrong data comes out, but continually. We have incredible checkpoints. Everything is sent out and tested for stability and qualitative and quantitative analysis before it's allowed to be compounded. We still do a lot of manual stuff, so that's an issue for us. Dispensing. Now, adverse drug reactions are a little bit different than your dispensing errors necessarily, or your I forgot to take it or didn't get to take it or I took too much. More your adverse drug reactions are polypharmacy. And that, we've always run and done statistics on outcome measures for that. We look at it through our database. When a pharmacist is entering the orders, now we're going to CPOE, which is a physician order entry. Pharmacists still have to verify all the orders. They have to manage the patient's profile and look to see what drugs can be mixed together, what drugs can't. So that's where we hopefully will reduce the adverse drug reaction.
Yeah, I was just hoping that maybe you've had a mortality decrease of some kind.
A mortality?
You know,
I can't say that at this point. You know,
how long have you been running this?
The robotic pharmacy,
Yeah.
We went live October 5th of 2010.
Okay, so let me wrap up. We're just about at the end with one last question to all of you. So let's just start in the same order. Let's start with you, Scarlett. What's the most exciting thing as you're looking forward, and what do you think is going to be the biggest challenge?
I think probably the most exciting thing is the safety aspect of what we're doing. We've taken, the more you move the human element out of it, I hate to say this, the safer that it actually gets when it's done by a robot that can't say, oh, I don't want to do it that way today, I want to do it this way. So that piece to me is very exciting. I won't say it's the scariest part, but probably the biggest challenge I think that's out there is we're a big institution, we can afford this, and we're putting standards in place that your small community hospital or community pharmacy cannot do and stay alive. And what are we going to do? We're going to reduce it down to a monopoly of certain hospitals and certain